Next up, we're going to have Professor Amar talk to us about complications and cases. Challenging.
Thank you very much, Dr. Ashwin. Such a pleasure to have Eric also here with us. So let's talk on predestined endothelial keratoplasty. So this is Pdek, which we first started with Professor Harminder Dua. You can see you're looking at the endothelium on the top, okay? I've turned it upside down. So what you are seeing on the top is the endothelium, remember that. From the sclera, take a 30 gauge needle, go inside, and you see I've created a bubble. Now look at this bubble, it does not go to the periphery. This is a type 1 bubble. So where is the air? You have the endothelium, you have got the desmase, you've got the Dua's layer, and then the bubble, and then the remaining structure, which is stroma. If it went to the periphery, it's a type 2 bubble. That means basically you have endothelium, desmase, then the bubble, and then the Duas and the stroma. So we are not interested in creating the DMEC bubble, we are trying to create the Pdek bubble. Enter into this, inject trypan blue now, so that stains everything, dissect it, and now you have the Pdek graft ready. If you want, another way to do it is, you made the bubble, cut it a little bit, flip it, you can make a hole in the center, now turn it upside down, so if you want to do a marking, S-shaped mark on the graft, you can do that also. Both ways are available. This was a case referred by a top retina surgeon, Dr. Natarajan, one-eyed patient. You see, there was silicone oil there, so I've just taken off the silicone oil. Now you can see that pupil is bad, so I prefer to do a single pass, 4-throw pupiloplasty the way Ashwin showed. You can see the same animation, pass it from one end, bring it out, remember the number 4, and pull on both ends, and that is game, set, and match. So here you see, after I've done the 4-throw pupiloplasty, I've injected the graft. All you need to do is, you can see the trocar AC maintainer, I've got air infusion continuously. Look at the same patient, pre-op, post-op 3 months, 618, and you can see the fellow eye was no PL. So now let's move on to other cases also, which I thought I'll show you. We also use infant donors. That means the youngest we have used is a 9-month-old donor. Look at this patient, scarred cornea, Pdek on a failed dissect with 4-throw pupiloplasty post-op, 1 month, vision was 6/9. Look at another patient. This patient had an IOL there. You can see an anterior chamber IOL. We explanted it, did vitrectomy, glued IOL, 4-throw pupiloplasty, Pdek. Look at the vision, 9-month post-op, 20/20 vision. Okay. Now look at another patient, one-eyed patient, failed penetrating keratoplasty. Look at the anterior segment OCT below. And now you will understand, post-operatively, we have not removed the cornea. All we did is did a Pdek on the failed graft and make the patient all right. So this is Pdek with single pass, 4-throw pupiloplasty. What about reverse 4-throw? I showed you single pass. In reverse 4-throw, we are going from behind the iris. So what happens in this case is, and I have to give credit to Dr. Priya Narang for this also. So you see here, the knot or the tail goes behind the iris. The advantage in this is, suppose you're having a Pdek graft or any graft, the tail will not hit it. This was another case who had referred to me by Dr. Natarajan. This patient had been operated 6 times, see the scarred cornea, had gone in for routine cataract surgery only, and had got complicated elsewhere. Now look at the scar, it's so bad. So I'm doing a vitrectomy. You can see the trocar AC maintainer there. I couldn't see clearly, so I'm taking off the desmase endothelium complex there, and you can see that fibrotic tissue is stuck to the iris. So one hand is holding the fibrotic tissue, other hand is cutting with a scissor. I'm cutting the whole structure there, removing it off en bloc. Now you see inside, as I see, remove that structure, now I'm seeing there's something shining inside. And you can see that's a subluxed IOL. So I catch it anywhere. Luckily for me, it was a 3-piece IOL. Do a handshake technique, and I made my flaps there. All I'm going to do is transfer it from one hand to the other. Ladies and gentlemen, if you are not seeing, please understand, even I'm not seeing. Okay? That's that bad, that cornea. So first haptic is out. Now I do my vitrectomy, clear up the remaining mess. Now I try to catch the haptic anywhere. You see, I've caught it somewhere. Doesn't matter where. All you do is transfer the haptic from one hand to the other so that you can now catch the tip of the haptic. Once that is caught, externalize. So far, so good. Once that's done, now my next step is to tuck these haptics inside. So I take a 26 gauge needle, tuck this into the Chariot's pocket. Once it's there, this great system by Gabor Chariot from Germany, tuck it into the Chariot's pocket. Now I do the fourthroplasty. Now remember one thing, in this I'm also making a closed angle open. I'm also doing a pinhole so that any astigmatism gets neutralized permanently in this patient, because whatever the astigmatism, it does not matter. Whatever the HOA, it does not matter if you made a pinhole. Now you can see I'm doing the fourthroplasty, and the advantage in this is you can do as many times as you want. And it's a very simple technique. If someone has not done it, please, you can start on this. Remember the number 4, pull on either end, and that completes it. Once I've done this, you will see me now completing that pinhole pupil there. My Purkinje image is pretty okay there. Now all I do is, remember that I have to take off the remaining Descemet's endothelial complex. Most of it was already removed by me before itself, but anything remaining, I'm just checking it. I've got continuous air infusion from the trocar AC maintainer. Create my Pdek graft just like I talked to you before. Once my Pdek graft is ready, I take it, inject it inside. The question comes now, how did this patient do? So why am I doing Pdek? Why am I not doing D6 or DMEX? One, I use young donors. Two, my manipulation is easy. Third is, I do not get detachments, rebubblings. My rebubbling rate is about 3% only we have. Whereas if you see DMEC in books or literature, it's about 25 to 30% by people. So you can see the same patient, pre-op which I showed you, and look at the patient, same case, 45 days post-op. So now, I thought I'd show you something more here. Look at this patient now. This patient came to me from Philippines. It was so bad, I couldn't see anything inside anyway. So what I did was, I didn't know what to do. So I took an endolumeter from outside also I couldn't see, but I could see something moving around that eye, inside. So I make my scleral tunnel, but still I'm not seeing with an endolumeter from outside. So what I said was, I took an endolumeter inside the eye. And now you can see that iris claw IOL there. Half is stuck to the iris, half is sinking. Using the endolumeter inside with one hand and a forceps in the other hand, I catch it and I explant that IOL. Once that's out, I now go in with the glued IOL technique, and you can see me doing that just now. Once that is done, my next step is to do, obviously, I need to make that pupil small. So I'm going to do the pupiloplasty. I already have a large incision, so I just used to implant it like a non-foldable IOL, tuck the haptics inside. Once that's done, now I start my pupiloplasty. But look how friable that iris is. Wherever I touch, it starts tearing. This portion is done. Now when I start at the other side, I'm breaking the peripheral anterior synechiae. I'm trying to do it, but I just am not able to continue it because of the visualization problem. So I thought, let me stop for some time. Let me try to remove this bad endothelium Descemet's complex. You see how bad that Descemet's endothelial complex is? And most of this fibrotic tissue is also stuck to the iris, as you can see there, see? So you would hold it with one hand. With the other hand, I'm cutting it with a vitrectomy probe. Remember, this patient has come all the way from Philippines to me. I have only one chance. Obviously, he cannot go and come back. A top ophthalmologist from there had referred this case to me. Now I continue to do this surgery. You can see my Purkinje image is bank center, but there's an iridolisis there. So I use the trocar-assisted iridolisis which we published. Basically, it fixed a trocar right opposite the iridolisis. Double arm Prolene needle. You see, pass one, pass other, pull. Once you pull, you tie, and you clear up the iridolisis. So that's the way to handle iridolisis. I'm doing that on one side. Once the repair is done, now the next step which I move is to create my bubble there. Once I do that, again I have got my graft ready, inject it inside, and then let's see how this patient behaved. So you can see that's the graft there. After injecting the graft there, you can see now, I don't use a marker, but you can if you want. We use the endolumeter, which gives me a very good effect there. So fix the glue. Question comes, how did this patient behave? Look at the patient post-op, day 4, and look at the same patient, post-op 2 weeks, vision improved to 6/12. And look at the pre-op, how bad it is, the cornea. I couldn't see anything. And that's the patient post-op. Look at this picture here, infective keratitis. So bad the cornea was, they did a therapeutic penetrating keratoplasty. Wait for 4 months. Don't worry, it will fail. Don't worry, let it fail. Okay, we published this in the cornea also. Once it has failed, Now what I'm going to do is I'm going to do a phaco in this. So you have a very bad corneal ulcer, not manageable by medical treatment. You have done a penetrating keratoplasty. Wait for some time. Let it fail. Now after 4 months, I've done the phaco. I'm going to do the photoreopuplasty. Once my photoreopuplasty is done, then you see me now. I'm making the pupil smaller and smaller. Now I know this patient has got a huge PK. Remember, there will be astigmatism. I make it pinhole, zero astigmatism. I don't care what the astigmatism, whether it is 10, 20, 5, 6, doesn't matter to me. Either way, I've neutralized it. Once that's done, next step for me is to do the Pdek on it. Again, you can see we created the bubble there, remove the Descemet's endothelial complex, and once you have done that, you can see I'm injecting this graft there. Once that is done, you'll see me in a second seeing this patient post-operatively, how this patient looks. Look at that infective keratitis, post-therapeutic PK, and you can see now 3 months post-op, how the patient's vision is 6/6. If I can have just time for one more presentation, which I'd like to just show on. This was a one-eyed patient who had come to me. Now, this was the only eye of this patient, okay? So let's see this case also. This was the patient. Look at this, dropped IUL, bullous keratopathy with hazy cornea, and there is a huge ciliary staphyloma, okay? The problem here now is, what do I do? I can't do anything on the top. If I cut there, I'm gone. So I make my flaps, and they were not 180 degrees, so I make it better to make the flaps 180 degrees. Now this patient had a one-piece, non-foldable IOL inside. Remember, this is the only eye of the patient. So I go ahead and do my vitrectomy, and the technique we use is the ECAL, which was started by Ashwin, basically, and through that hazy cornea, you can see that single piece, non-foldable IOL lying inside. We use the cannula, extrusion cannula assisted levitation after vitrectomy, using the suction, pull it up, shift to a glued IOL forceps. So I've done that. Remember, this is a one-piece, non-foldable IOL. If I'm not careful, it will break. And if it breaks, I'm gone because I don't know how to explant it. There's no space for me. That huge ciliary staphyloma is my problem. So now, I've caught the haptic, and you can see that's the PMMA haptic. Be careful when you tuck, because you can't flex and tuck. Withdraw and tuck. Now, once that is done, now I move into the surgery of, again I do the same process which I've been talking to you about. Do the photoreopuplasty. Make that pupil a bit smaller. Break the sine K. Convert the, simple what I'm trying to tell you is to convert the basic idea here is to convert the closed angle to open angle. Once everything is done, and I made the pupil pretty good as much as possible. Remember that huge ciliary staphyloma is there. Now all I need to do is take off my endothelium Descemet's complex there and implant my Pdek graft. So here you can see I'm just continuing to do the pupiloplasty. Once that is on track there, and I've closed every bit as much as I can, I understand the problem will be there in such cases. I go ahead and do my vitrectomy probe to make my pupil bank centered and round exactly the way I want it to be. And you can see that Purkinje image P1 is bank centered. So now let's see how the case does at the end. Once everything is done there and my pupil is well centered properly, I'll just go in, take out my Descemet's complex. A little bit of iridectomy area is still damaged there. I would like to close it because that air will go back otherwise. And then I'll have a problem of my Pdek graft, so I don't want to leave anything behind unnecessarily. I'd like to close all these small defects also, so that no air goes posteriorly. So the advantage, why do we not get a rebubbling is basically this. In the Pdek graft, remember, you're having duas, Descemet's, and endothelium. The duas and the Descemet's are fused. They cannot detach. So you are sticking dua to a dua. So there are two duas layers in Pdek graft. And that is why you don't get rebubbling present in Pdek graft. Whereas in a DMEC graft, you're sticking the duas to the Descemet's where there is a space or a gap present, which can obviously detach and which produces the bubbling. So the final picture, and then we'll move to the next speaker here, is this. I'm injecting the graft. Remember once again, ladies and gentlemen, this is the only eye of this patient. It was a young patient. So after everything is done, let's see how this patient behaved at the end of the day. This is the patient post-op day 1. And you can see now 1 month post-op, ladies and gentlemen, we did dropped IOL, bullous keratopathy, ciliary staphyloma. We did the ECAL technique, did the gluteal, did the fourthroplasty, did the pinhole pupillasty, and ended it with Pdek. Thank you very much.
Thank you, Professor Amar. Next up, we have Eric Mertens. Obviously, while he's setting up, I'll ask a question. Are there any cases you say no to? I will not do this case.
If by chance it is very, very bad, by and large, I tell people it's really badly scarred. By and large, I would manage them with these. Many cases which you would go for Boston keratopathy, we do the Pdek. I will say do a PK, then it's much better off. But even in PK, please understand, just doing a PK in a pseudophakic eye makes no sense. Make a pinhole, then only the patient will be able to see clearly without glasses.